the next session, that is the role of psychoneuroimmunoendocrinology in endocrinology disorders. So the moderator, Dr. Vani Kulhari, we have with us. She's a psychiatrist in Mumbai. She has done her MD, completed training in psychiatry from Nimhans, Bangalore in 2003. She has worked in diverse settings from public sectors, charity, private practices, NGOs, and jumbo COVID centers. She has done her research in cannabis psychosis and case of inconsistent parenting, which has been published in international journal. She has contributed 2 chapters of psychosocial aspects in the Southeast Asia edition of Nelson's Textbook of Pediatric. She is the member of Indian Pediatric Society Committee on Mind-Body Medicine. She is presently working as an independent psychiatrist in private practice and as a pediatric psychiatrist at Nanavati Super Specialty Hospital, Mumbai. Over to you, ma'am.
Thank you for this opportunity to moderate this session. I would now call upon my colleagues, esteemed colleagues, the experts who will be participating in the panel discussion. Our first expert is Dr. Mangesh Divakar. He's my colleague from Mumbai and we belong to the same branch in the Indian Medical Association. And that was a very close introduction last week. Sir has been a gold medalist in his MD medicine studies and an honorary general secretary of the National API. Recently, he has also been appointed as the editor-in-chief of the Journal of the API. He has been on editorial board, the guest editor of various journals, so you can see his research interests. Delivered more than 1,000 lectures, 64 publications in various national and international peer-reviewed journals, and has multiple chapters, write-ups, and textbooks to his credit. He's an MRCP examiner for the Royal College of Physicians, UK. Welcome to you, sir. Our next expert, can I have the slide, please? Dr. Shripad Pujari. He's a neurologist practicing in Pune. Shripad, can you come and join me? He's presently attached to the Dinanath Mangeshkar Hospital, where he is a practicing neurologist as well as a teacher guiding many students doing their neurology study. His educational training, he trained in neurology at the Sir J.J. Hospital, Mumbai, and has followed that up with fellowship and research in London. Multiple sclerosis, neuromyelitis optica, and neuroinflammatory disorders are his special areas of interest. He has several publications and he's known to be a very good writer and often called up by his colleagues to process and write up all the research articles on their behalf. He's actively involved in educating resident doctors, physicians, and the general practitioners, as I mentioned before, and involved in various patient awareness and education programs. A hearty welcome to you, sir. The next panelist is Dr. Vaijayanti Lagu-Joshi. Ma'am. She has done her MBBS and MD in medicine from the BJ Medical College, Pune, followed it up with further training in rheumatology at the KEM Hospital, Mumbai, and the EULA certificate course in rheumatology. She's a member of the American College of Rheumatology and member of the Indian Rheumatology Association, presently working as a consultant rheumatologist, Center for Rheumatic Diseases, also at the Dinanath Mangeshkar Hospital in Mumbai, and is an ex-visiting faculty for Rheumatology Fellowship at the Bharti Hospital. She is the principal investigator for Urban Population Survey for RMSD in Pune. She has publications regarding the same in the Journal of Rheumatology. Also an investigator for multicentric clinical drug trials, multiple oral and poster presentation in national and international conferences. And today, this is her second participation. She has just attended one presentation in the morning representing her work, and this is her second presentation. Welcome, ma'am. So when we come to this topic, that is the role of PNIE, and we have a kind of variety of experts with us from diabetology, neurology, and rheumatology. One of the things that we feel is that what is the cross-pollination. And we want to start with the numbers. So I would like Dr. Shripad to tell us what would be the proportion or percentage or numbers of patients with endocrine issues or diabetes that you encountered in your practice, sir?
Yes. On extensively reviewing literature, I did not find a specific number quoted for endocrinological problems and diabetes patients attending neurology clinic. But what I found was in a standard neurology OPD, there were many studies, and a couple of studies I have quoted, one from Karnataka and one from abroad, Saudi. Between 9 to 10% of patients were stroke, and then around 4 to 6% patients consisted of peripheral neurological disorders, mainly peripheral neuropathies. Carpal tunnel syndrome, as you know, is one of the commonest mononeuropathy patients present with certain cranial nerve palsies and myalgia. So, general chronic pain and myalgias. So putting this together, and if we see this way, stroke, and then stroke, one of the commonest risk factor being diabetes. Second, peripheral neuropathy, carpal tunnel syndrome. Again, diabetes is one of the main predisposing or precipitating factor. Obviously, with carpal tunnel, you again have thyroid diseases. And then other single cranial nerve palsies, as you know, Bell's palsy, or sometimes patients may develop abducens nerve palsies. Even those are one of the classic features of diabetes. So taking all these numbers together, around 15% of patients that we see are those with one or the other complications suffered from diabetes. And then in the second most common illness intersecting is thyroid. And as you can know, hypothyroidism rarely presents to me with depressive or mental slowing, pseudo dementia as we call, and then hyperthyroid will present with anxiety symptoms, tremulousness, rarely with Graves' ophthalmopathy. And then even less commoner or uncommoner are those pituitary adenomas, which many times present to us directly with visual field defects. Then SIADH as a part of either it would be, it's very rare to have de novo, but commonly because of intracranial infection like meningitis. So all these things put together, a good 15-20% patients attending us have one or the other endocrine problems, which means 1 in 5. So that is the incidence.
Since we are on the topic, I think if you can also tell us what would be the 3 key linkages between diabetes and the central nervous system.
Yes, when Sphere allotted me this topic, I was I got so interested that I went on reading dozens and dozens of articles, and it's really so vast and so much to understand in this area. Can we have the slide, please? The slide that I have prepared for that. So there are literally more than half a dozen ways by which diabetes and other endocrine disorders would affect nervous system and vice versa. Broadly, just go up to 2 or 3 slides ahead. So the way I have simplified it is there are 3 main areas. First, let us look at how what is the control of nervous system on diabetes, the diabetes as a disease itself and endocrine system. And then you can look at it as broad and a gross anatomy, wherein can you go ahead for a couple of slides? So as we all know, autonomic, that is the sympathetic and parasympathetic system, has a big influence on pancreas, which culminates into diabetes. And we all know there are 11 nuclei in hypothalamus, of which 4 to 5 nuclei subserve a key control on metabolism, eating, sleep, insulin sensitivity, and lipid metabolism. So that's at a broader, grosser level. And if you see my second point, then let's go to micro, that is the molecular level, either at the level of neurotransmitters, neuropeptides, or hormones. We all know the first 3 bullets. When the peripheral insulin is low, obviously the cerebral insulin also drops. This alters the sensitivity of brain, and as you know, it culminates into insulin resistance. We all know the popular glucagon-like peptide 1, which now is one of the hot molecules we are trying to incorporate into treatment Again, weakening of this would again cause insulin resistance. We all know about leptin. And then the core, our core neurological neurotransmitters, of which the most important being dopaminergic. And if you have less of dopaminergic, it activates the HPA axis. Cortisol, sympathetic, the standard thing we have been talking again and again will lead to hyperglycemia and all the metabolic problems. Serotonin. Now, normally, if we give SSRIs, we feel there is weight gain and increased appetite, but there are many receptors in serotonin, of which one particular, you don't have to remember one, but that is responsible for less eating and reduction of appetite. And if there is reduced stimulus to that, then that may, on the opposite side, cause eating disorders, which will be a problem. And then melanocortin, another important one, reduced activity of which will cause, again, insulin resistance. And then the other way around now, let's look at it, how diabetes will harm the nervous system. The first bullet, I think we all know, right from top brain, which includes metabolically to causing small vessel disease, then the eyes, and then the neuropathies that I talked of. Two, I'm sure you all remember a couple of Dr. Das and Dr. Sahay and other people mentioned about increased incidence of, they're actually coexistent. Diabetes and Alzheimer's dementia, and diabetes through small vessel ischemia will cause vascular dementia. So this is the least we should know. There are many other things, but this is what I try to simplify to.
Dr. Vaijayanti, your work is constantly about immunology and the inflammatory processes. And how would you see that in linkage with the endocrine system that we are discussing today?
True. In this today's session of PNI, definitely we are focusing on psychology, the neurological thing, endocrine, and we want to somewhere link up to the inflammatory or immune system dysregulation. Everybody has its immune system responses in the body in response to some kind of stimulus. Either it may be an infection or sometimes it is a self-antigen itself. So those immune responses which are against these self-antigens are called as autoimmune disorders. And here we see typically as far as diabetes is concerned, in type 1A diabetes and type 2 diabetes, we see two different kind of phenomenon. Here the type 1 diabetes is supposed to be a very organ-specific autoimmunity, where there are antibodies against the specific beta cells of the pancreas. While in type 2 diabetes, it is more of a meta-inflammation disorder, where there is a crosstalk between the inflammation and the metabolism. So in type 1 diabetes, there are minor changes like, sorry, the slide. In type 1 diabetes, there's something called as insulitis to begin with, where there is an inflammation, there is an invasion by T cells. Mainly, it is a T cell mediated phenomenon, and there is a destruction of beta cells. While in type 2 diabetes, we see the inflammation running in different organs. It is not just the pancreas, but it is also the liver. It is also the muscles, where the inflammation and adipose tissue, obviously. So the three together, concurrently, the inflammation going on, and there is an infiltration of this adipose tissue by the macrophages. So basically, those responses are mainly mediated by innate immune system, while the organ-specific immunity, we see more of the adaptive immune response through T or B cells. So this is a basic difference between a type 1A diabetes and type 2 diabetes. Very important to understand, because in type 2 diabetes, we have to tackle the inflammation more rather than the autoimmunity part. Well, in type 1A diabetes, you have to tackle the autoimmunity part, which is important. The orchestration of all this inflammation is through various inflammatory mediators, which are called as cytokines or chemokines. And mainly in type 1A diabetes, we see this interferon gamma, TNF alpha, then interleukin 1 beta, which are main mediators of inflammation. Well, in type 2 diabetes, as macrophages play main role in inflammation. So again, TNF alpha, interleukin 6 is a very important, leptin or adipokines. They play a major role in the inflammation. So basically, it is a chronic low-grade inflammation which we see with type 2 diabetes, which keeps on going. And that's why generally, whenever there is an acute infection, the immune response occurs and it gets over. But whenever there is a chronic low-grade inflammation, that immune response keeps on ongoing, and that produces the damage to the tissue.
So that's a very interesting thing, the inflammation going to various organs. Our senior expert, Dr. Tivaskar, sir, going from here, some of the inflammatory mechanisms have been explained. We want to discuss the mechanisms and types of chronic pain in diabetes mellitus, sir.
Yeah, so thank you very much. Good evening, everybody. And it's so nice to see you all sitting, even though this is the last session. And kudos to Dr. Vaishali and the entire team Synapse. And thank you, Dr. Vani, for that beautiful question. And good evening to my fellow faculties as well. Now, as far as the different mechanisms of chronic pain and how they are related to probably psychoneuro, immune, endocrine response differences, probably one thing is for sure is this, that usually this chronic pain, no matter whatever could be the origin, and especially in diabetics, when you know that chronic pain can be, right from macroangiopathy to microangiopathy, commonly presenting you with restless feet or very unpleasant sensations in the feet. And there are so many other ways: chronic backache because of the deposition of the advanced glycation end products in the orthopedic and in the skeletal tissues. So usually what it triggers primarily is again the same thing that Dr. Patwardhan was talking about. That was the stress related hormonal dysregulation, which actually is more culprit. Basically, we need to understand that any kind of a stress, no matter it could be an acute stress or a chronic stress, even though the rapidity of the response may be a little different, but overall the interaction between the immune, the metabolic, and the endocrine response is through the hormonal dysregulation, right? And mostly there we are talking about the hypothalamo pituitary adrenal axis responses, which happens through usually through the stress hormones like cortisol or vasopressin or renin, or you're talking about glucagon. Or there is also a sympathomimetic or a sympathetic nervous system response, which would be through either an epinephrine or a norepinephrine response. But ultimately, it leads a disruption at three areas. Number one is the metabolic disruption. Number two is the organ disruption that happens. And number three, and one of the most important challenges that usually diabetic patients they face whenever there is a stress and a chronic, is the psychological disruption. And remember that all this will alter your overall immune behavior. So we all here sitting, we need to understand is this, that no matter whatever systemic challenges that we talk about, whenever it comes to the mind involvement, remember that mind is the driver of your body, and you cannot have a wrong driver sitting to drive the life, the vehicle of your life. So I believe these are the different mechanisms. I tried to be very short because it has been beautifully alluded by Ganpati and Patwardhan sir and even Gagan. They spoke so beautifully about the various mechanisms and the types of the chronic responses that can be elicited by the chronic pain in diabetes. Over to you, Dr. Vani.
And since recently, I think the biggest experience or teacher of stress has been the pandemic. So what?
Yes, yeah. In fact, COVID has taken it to a different level altogether, and we know that COVID, apart from the immunological challenges it posed, what was more difficult and very dangerous in the patients of COVID was the neuroinvasive and the neuropathological and the psychological challenges that the patients they faced, and that they triggered a very abnormal dysregulated immune response in the patients. And in fact, we have seen, now I was in a very active COVID practice, and I have seen that, that whenever there is a stress or a fear psychosis, or wherever there is an anxiety which is at the peak of by just diagnosis of COVID, these patients, in spite of being stable clinically, had a very torrid in hospital time or even in the OPD time, and there was probably some mortality as well, because these patients they had a much more severe and a very serious dysregulated immune responses, which were responsible for probably sometimes development of an acute ARDS or the respiratory failures or the complications related to COVID, including coagulopathies. So I believe that this was a biggest learning lesson for us. That again, one thing is this, that how you accept the insult, how your mind takes it, determines ultimately the outcome of the disease. Especially COVID was the biggest teacher.
I'd like to ask Dr. Vaijayanti, I think both with respect to endocrinology with respect to certain psychiatric disorders, as well as with respect to her practice in rheumatology, women seem to be the chosen candidates. So what are the gender related observations, issues, or biological things that you would like to highlight?
Surely. This is a good question. And yes, women dominate everywhere. And so is in rheumatological disorders, or maybe it is metabolic disorders. Yes, that's a fact. There is a gender bias by nature, I think. First of all, the nature has allocated that extra X chromosome to all females, and that is playing some game here. And there are definite immune related genes which are located on this X chromosome, which also are responsible for being fragile for mutations or playing havoc with the disorders later on. That is one thing. And second thing, the hormonal milieu, what female has got, definitely has a role in inflammation promotion or inflammation suppression. Especially when we look at the number of cases, like suppose I see the systemic lupus erythematosus cases or rheumatoid arthritis, definitely we find more female patients compared to males. As much as the ratio is 3:1 for rheumatoid arthritis, and for SLE it goes right up to 10:1. So out of 10 patients, 9 patients are females. And that too are very in young age group. So they are between their 20 to 40 is a very, very important age group to develop those autoimmune disorders. And definitely the answer lies in the hormonal milieu at that time. The estrogen, which is in high levels at that time, peak levels at that time, as well as the prolactin, they are supposed to be the pro-inflammatory kind of hormones. They do stimulate the immune systems. While the progesterone and the testosterone and androgens are supposed to have the anti-inflammatory kind of or immunosuppressive kind of actions. So that's why we do see flares, especially during the cases where there is surge in the estrogen. The patients of SLE taking OC pills definitely will land up with SLE flares, or those patients during pregnancy can show some flares. However, there are some diseases which will show a good remission during pregnancy because of the progesterone dominance. In rheumatoid arthritis, especially, the patients will show a definite good remission during the pregnancy. But as soon as the pregnancy is over, the prolactin surges occur, again they land up with the disease flares. So definitely the hormones do interact and do flare the inflammatory disorders. I think that's it. And basically
Yes.
it is these hormones do have a role in adopting the immune cells, especially the B cell responses. They are more in females, especially B cells are more autoreactive, then do produce more immunoglobulin levels in females. So those are some reasons why the females dominate in rheumatic disorders.
Yes, I just want to add one sentence. If you have heard, there are terminologies: catamenial epilepsy, menstrual migraine. So from this you can understand what
I think Dr. Tivaskar can also add some light on gender differences in diabetes and also the kind of stresses. Maybe the stresses in the lives of men and women are a little different. So from
Yeah, in fact, but let me tell you, Dr. Vani, is this that overall, as the law of nature, as women being I would say progenitors and the progeny givers, so life givers. Primarily, the immune responses, overall metabolic responses in women are much different than in men. Women have a much more potent and a very, very highly evolved, I would say, immunological responses, and they are more protective, especially whenever they are in the fertile age. And in fact, very interestingly, we do not talk too much about the various chronic metabolic diseases in women, but probably a couple of weeks back in one of the women in diabetes conferences, I had an opportunity to speak on the gender differences in the lipid management and the dyslipidemia patterns of women, and we could find out that there were so pronounced differences as far as the patterns of dyslipidemia, which are very common in men, and the patterns of dyslipidemia are very common in women. Like in women, there is much more higher amount of hypertriglyceridemia seen in comparison to males. The LDL receptors and the LDL challenges are much higher in men than in females. So all these final integral parts are there, but as an overall, my take on this is this, that women are much more armed better to handle the stress and the stress related, not only immune, but also immune endocrine hormonal responses much better in comparison to the male gender.
But I think this is also a typical case where the weapons turn against the
Sometimes, sometimes, usually when, and but this is usually not the weapons turning are, around. I would say it is primarily because of the failure of the proper regulation. So again, this is a dysregulated response sometimes in some peculiar situations that you experience.
I think since morning I've been observing, and Dr. Norman Sartori has also told us that we doctors now should be used to treating and seeing a patient, and a patient essentially doesn't come with one disorder at a time. Usually there's more than one disorder, and these disorders are best friends in the way that they're increasing each other. So I would like to ask Dr. Shripad, what approaches would he suggest to manage such complex situations?
Absolutely. The terminology that now we have started to use for many disorders is now multidisciplinary approach. And at least for my inpatients, definitely, and to a large extent to the OPD patients as well, this is what we all have started to do. And I think we are going to have to do it more and more. I am just going to elaborate it a bit more by a standard simple case that we come across. I'm sure all of the physicians and all of you have seen this. So here is a typically 55-year-old male CEO of a big firm, high achiever, and with a lot of expectations by the board. And he's a smoker, and because of the frequent meetings, indulges in alcohol, say twice a week, diabetic, poor attention to health, overweight, doesn't have much time in life. And he attends my OPD for peripheral neuropathy, sleep disturbances, and I prescribe. And then his the first consultation goes like more of symptomatic. And then he lands up in our hospital with acute ischemic strokes with typical high sugars and BP. And then this is exactly what I began saying. How do I approach? First, we have to address the emergency acute ischemic stroke. We have to do whatever thrombolysis, acute stroke care. Usually it is done with a physician who manages the sugar BP, which will be followed by physiotherapy, the rehabilitation. And then in the last few days before discharge, obviously I involve nephro, ophthalm, food care to assess the end organ involvement. Physician assesses for the cardiac issue, ischemic heart disease, and if required, cardio is involved. Endocrinologist for the diabetes, metabolic assessment, and advise weight reduction, diet planning, and whatever more issues are. And obviously, the most important becomes psychiatry and psychology, where stress management and the ones I have written in bold, counseling that man, prioritizing his health now above other matters, importance of risk factor control, de-addiction, etc. So things go on. So this is how I have to really manage my patient, and I can't skip on any one of these.
The education to live with the disease once you have managed whatever emergencies come from. I think the other common platform that we see is a lot of pharmacological agents that we use. And I would request Dr. Vaishalideshmukh to tell us that when in your rheumatology practice, what you consider that, okay, the endocrinologist and we are using these common agents, and what should be kept in mind? Like how we, in the morning, sir explained about lithium and thyroid. This is something that endocrinologists and psychiatrists have to keep in mind in terms of common medications. So can you just put a light on that?
Thanks to this panel, Vaishali, because I could read the role of immunomodulators or cytokine therapies in diabetes, which I was absolutely unaware. I mean, I know that this type 2 diabetes is a metabolic syndrome, and it is a kind of insulin resistance and supposed to be now as an inflammatory syndrome. But I was not really aware that you have you really started, but I am seeing the going through literature, I'm seeing the clinical trials ongoing. especially for the antibodies which tackle the specific cytokines. As I said, if the basic problem in type 1 diabetes is T cell mediated and it is a specific organ specific immunity, that's why they have come up with various antibodies for that. Again, there are two approaches. They are non-antigenic specific. There have been trials with anti-CD3, rituximab, that is anti-CD20 B cell therapy, which we routinely use now for rheumatoid arthritis or SLE patients, is being used for diabetes mellitus as well. But here I think while using these antibodies, the evolution or the time should matter definitely, because when already the destruction has occurred, I don't think there'll be a role of this kind of immunomodulation in that. But I'm seeing a number of trials which are there with those immunomodulators, what we use for ongoing inflammation. And there are some antigen specific approaches, especially for type 1 diabetes also there. Well, in type 2 diabetes, which is a common ground, where the patients of diabetes, hypertension, dyslipidemia present to us with osteoarthritis. So basically they come to us with knee pain, ongoing knee pain and chronic osteoarthritis. And definitely here we do use sometimes the non-steroidal anti-inflammatory agents for their pain relief. And somewhere I'm again looking at the literature in type 2 diabetes also, these non-steroidal anti-inflammatory agents were also used for tackling the inflammation which is ongoing there and was giving some benefit for the sugar control. Even the insulin and metformin, which is being used for diabetes control, is also having some anti-inflammatory mechanism and also useful for some rheumatological pain, especially for osteoarthritis knees. TNF alpha blocking agents, which we use for rheumatoid arthritis, psoriatic arthritis and all, which actually block this TNF molecule, which is the main orchestrator of all the orchestra of cytokines and chemokines. So far we were reading in rheumatology about the case series or case reports where the TNF alpha blockers being used on a long term were giving rise to hypoglycemia. And that's how the case series was published for that. But now here I am looking at the literature for diabetes and they are saying, no, it is being used for type 2 diabetes now to tackle the inflammation which is ongoing there. So definitely there's been now a good scope of these agents, immunomodulators and cytokine inhibitors in diabetes as well, per se for diabetes, not just the metabolic syndrome, per se for diabetes. So etanercept or infliximab, which is being used. Then, yeah, sure. Steroids are definitely we do use steroids as an anti-inflammatory agents, but generally we reserve it for what we say higher order of inflammation. Just for mild arthralgias or mild degree of inflammation, generally non-steroidal anti-inflammatory agents are the first choice. But whenever it comes to the system involvement, whenever there is a systemic inflammation or a life-threatening life-threatening inflammation or organ involvement, specifically like kidney or eye, somewhere where you need to act fast, then definitely the steroids will be the drug of, first choice.
Vaijanti, if you can allow me, can I come in? Yeah, here, Mangesh. Dr. Vani, if I can come in here. So as the Dr. Vaijanti, the best example that I can think about in this is again a simple high use of hydroxychloroquine being used as an anti-diabetic agent, really a fourth line anti-diabetic agent, but primarily it is an anti-inflammatory drug which Dr. Vaijanti is using in a day-to-day practice. So probably this is one of the drugs that is really has shown us that anti-inflammatory interventions in the management of type 2 diabetes have a role to play. And COVID again has taught us that biologics are the futures. And this is what all the names which were so non-familiar with us, in the previous, I would say the before COVID era. But now we are in probably the post-COVID times. We all are aware about all these MABs and CEPs and, everybody has heard about the biologics. So, and the biologics are going to be the future because they are going to be the future of the medical therapy, because they are going to be the precision medicine bestowing drugs, which will be very, very determining as not only the outcome of the acute diseases, but the chronic metabolic disease as well.
So that is what actually I wanted to ask you. You mentioned that you had a big COVID practice, and then dexamethasone was a big, huge part of our firefighting arsenal. But then 2 months down the line, so can you just summarize your experiences with the PNI theme in your background as to what were the learnings of using this and diabetes and so many other?
Yeah, and thank you, Dr. Vani, for that wonderful question. The whole learning session for me, or I would say the whole learning experience for me during the COVID time was that apart from the medical and whatever the interventions, we probably sometimes use them blindly, whatever the therapies, the interventions, every possible, I would say, efforts that we did. But what probably was one of the key determinants of the success of the outcome of the COVID related challenges was a good positive mindset of the patient. You know, accepting the diagnosis, understanding the possible complications, and willingness to face it has been one of the key features of the COVID recoveries. And that is the place where, really, as Dr. Pujari is going to answer your next question, is that that is the place where your yoga, your meditation, I will not interfere in his area of the answering, but that is the place where, the patients, those who have, and I'll tell you my own example. I was admitted in the hospital for 11 days with moderate to severe COVID, and I was treated by my team, including myself, in my hospital. I have received 2 shots of tocilizumab. They were possibly the acute inflammatory dysregulated response which was setting. But I was lucky enough to receive the tocilizumab at the right time, and the things they settled on Neuro. But what I've realized in my that 11 days of hospital stay is this: that keeping yourself psychologically, upright, being in a very positive frame of mind, believing in the possibility and willingness to fight probably has changed the outcomes in not only me but many of the patients that have undergone this moderate to severe disease.
I agree. So even I worked in the COVID jumbo hospital, and my key finding was the patients whom I treated with sedatives so that they could have a good night's sleep on the day of admission. They did much better in terms of the outcome. So very simple intervention, just 3 milligrams of melatonin, some counseling, and they seem to be doing much better. So, Dr. Shripad, would you like to I think since morning we've had a lot of discussion on this. Would you like to comment on this yoga and role in diabetes? Just a small summary.
Made a preamble in the form of my 3 points as to how the brain has effect on diabetes and vice versa. So if you see, we all know, I think Dr. Shivram, Sai, everybody raised Ashtanga Yoga, the 8 aspects. I have just simply put down, and all these points are picked up from, though they are small cohort, but trials. And so there is evidence behind this. And barring, and so I've just picked up 2 areas, yogasana and meditation, and barring a couple of points here, which pertain to pancreas, this one and this one. If you see, the yogasanas have a favorable effect on body weight, adiposity, and insulin resistance. Again, this pertains to hypothalamus, and they increase the blood supply to the muscle. Again, it's the neuromuscular system which they produce effect on, and along with that, with the pancreas, they would, and then the effect obviously on inflammation, and all put together have a positive influence on diabetes. And likewise, again, we go back to the hypothalamic pituitary axis, catecholamines, cortisol, and thyroid function. You just saw me showing the pathogenesis. That again, in a small cohort evidence-based study wherein they measured these either neurotransmitters or hormones and showed that they modulated in a favorable way by improving glucose metabolism. That is what I wanted to just display.
So actually, we had planned a few points and we have put forth those points, and this is a learned audience. So I would like to ask the audience also to participate by sharing their comments, experiences, or questions, because we have some time, and that would be very interesting to have your contribution.
In the history of medicine, this may perhaps one of the rare occasions, when we really are having a very practical discussion around the PNIE, because we have been talking a great deal about it, psycho, neuro, immune endocrinology, but it is the first time that we actually are getting into the nitty-gritty, both pharmacotherapy as well as the non-pharmacotherapeutic interventions. So the point is that, going forward, and if I may take the liberty to pick up a point from each of you, and it is my sort of a cherished wish that only if we were to have a protocol to assess patients on all these four dimensions, psycho, neuro, immune, and endocrine dimension, then the next point would be that we would know that, that which system of this is like bit more out of the normalcy or out of regulation. It could be in some instances, it could be a one system which is predominantly out of sync, or on the other extreme, we could have a situation in which, all the four have a substantial derangement, because this would also lead for a sensible choice, multidimensional pharmacotherapy, multidimensional non-pharmac intervention as well. So we are not talking here of polypharmacy. See, there is a difference between polypharmacy versus this kind of a multidimensional intervention. So whether it's a patient of depression or whether it's a patient of arthritis, if you find that whichever system is out of sync. So if like in the morning, Dr. Sanjay Kalra made a very nice presentation, about the autonomic dysfunction. So if you find that it is predominantly a sympathetic overdrive, then you have to manage that point. If there is a predominant, in addition to the sympathetic overdrive, if you also find that there is a clinically significant inflammatory part. So in other words, it is quite likely, that we are treating as part of our individual verticals within medicine, we are treating patients in piecemeal, and could be a reason that why we are like short of optimum outcomes. So if we have to, sort of optimize really our outcomes, we possibly need to have a composite sort of PNI, sort of an assessment in the first place, which would tell us, that what thing is out. For example, this very nice discussion between, as they said, they searched the literature and they found, incidentally, it is well known for a very long time in most psychiatric disorders. I had a teacher 35 years ago, I was a resident long ago. And my teacher at that time, Professor R.S. Pandey, he had done actually as part of his MD thesis, anti-brain antibodies in schizophrenia. But I never heard, and later on, subsequently, the autoimmunity as well as inflammation is a part and parcel of every psychiatric disorder. But I have never seen actually, any immune therapy ever being conceptualized, about tackling any of these disorders. So we perhaps also fallen prey to certain kind of a bias, that predominantly whatever the symptoms are, you sort of it's like a paracetamol approach, patient has a depression, so you in a very linear way, administer the antidepressant, patient presents first to her, with some inflammation, so adhere to the anti-inflammatory. So we have to, I think, get out of the individual biases, possibly make a multidimensional sort of an assessment.
One sentence, sir.
Yeah, sure.
You said poly, na, so it just struck my mind, polypill. So our present practice is prothrombotic, stroke या MI हुआ, aspirin, cholesterol, statin, triglyceride, fesofibrate, blood pressure, ACE inhibitor, 6. तो ये कोई नहीं देख रहा है कि hypothalamic pituitary meditation और उसको some kind of meditation और breathing exercises ये सब करके उसको prima facie change करो ताकि ये polypill की जरूरत ना पड़े. That's it.
I think one single word I'll add is syncytium. Body is a syncytium. So you can't take body into different parts, brain separately, heart separately. We have done that for the ease of treatment. But eventually body is a syncytium. What affects the hand affects the brain, affects the heart, affects the organs. So I think we need to learn to treat the body as a whole as a syncytium, though we are specialists in our own field. So I think once that word syncytium is used, you understand that it's a part of the same.
And as Tivaskar sir,
Pandava is economy.
Yeah.
The patient should be able to afford whatever we right. That should be the main thing, because if you can't afford anything, so all the efforts will go.
Can I request the speaker to use the mic, please? I was not able to hear what you were saying.
Okay, so I just summarize what he said. He spoke about actually the economics of the healthcare.
Mhm.
But in addition to that, I like to just expand the point which Divaskas have been nicely made, that in some sense, COVID has been a great, teacher and an eye opener for us. For example, like Vani spoke about the great value of simple melatonin or a small dose of clonazepam, which improves the sleep. So later on, people of course said that sleep is perhaps one of the real good immunity booster. You want to have a good immunity booster, it is perhaps the good getting a good sleep. And maybe a little bit sleep aid here and there. Similarly, if you remember Tivaskar sir, a psychiatric medicine, a SSRI called as fluoxamine. So
Correct.
thought that this antidepressant itself could actually have immunomodulatory property.
Absolutely.
Perhaps actually, starting with a classic example of aspirin, that starting with an analgesic and finally ending up actually as a blood thinner. So it is quite likely that we may even discover, once we have this psychoneuroimmune endocrine paradigm, we may discover, different usages for the existing medicine. Typically a line extension, sometimes what is also referred to as off-label usage. Sometimes the off-label usage is helpful in the sense, you find that there is a basic medicine and its value really extends, much beyond the typical use, the label use. So we possibly may even have, in addition actually to the, of course, the great benefit of the non-pharmac interventions, the mind-body medicine. Mind-body medicine, we always said, is a judicious combination of non-pharmac interventions along with pharmacotherapy. The idea is to fix the psychoneuroimmune endocrine dysfunction.
Like
Means are
polytherapy,
unimportant, means are unimportant. We are not here, sorry.
I would say like polypill, just 15 minutes in the morning you sit, do mindfulness, few breathing exercises, pranayama, om, and 5 asana. And we may not need a polypill. And we may not need a polypill.
That is the
You don't need
patient's
a
dream
polypill.
also.
Yes.
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 Yeah.
Absolutely.
Yes.
Primary as well as secondary.
All stages.
Yeah. So the
All stages.
point is, yeah, we will.
All stages. It is the different, whether the mind-body interventions or the pharmac interventions, they are the various tools available to us. The idea is that we optimize, their use, and we basically generate good outcomes and good quality of life finally for our patients. The means are unimportant, as far as if you ask me,
Right.
although I stand here as the task force chair of mind-body medicine, I would say that means are unimportant. Finally, what matters to patients are the better outcomes and better quality of life.
Yeah.
We shouldn't really, we have to therefore have, the true patient centricism. The true patient centricism is about finally minding the good outcomes, the good quality of life, and a judicious combination, wherever works, which works better. And that is wherein comes the important role of evidence.
Right.
Generating the clinical evidence of clinical efficacy, understanding the mechanisms better. And since that we know that PNI framework is something which is a practical means
Yes,
for
as
us
the
to integrate
Dr.
our ideas. I think
I
we
was
have to-
saying, Dr. Vaishalideshmukh has already devised a questionnaire, a PNI questionnaire, and she has already presented one paper wherein it has already been, partly displayed and endorsed, and we are in the process of refining that question. Vaishali.
Yeah, we are doing this question and now we have completed around 1,000 patients where PNIE assessment with simple questionnaires. It hardly takes 5 minutes to fill up that questionnaire. The patient fills in itself, so we don't have to employ anybody. And you just see the tick marks. So if you see that in the psychiatry section, the tick marks are maximally on the right, you understand that the psych is at fault. If immunologically the tick marks are on the left, the immunology is fine. So it's an easy look for a doctor to understand what is wrong in that patient, and then I can focus more because we have very less time to see our patients. So it's a clear indication of which system is affected in that particular patient. So a patient of diabetes comes, a rheumatologic patient comes, I see what is going wrong in the body and I try to focus on that system more. So I think this is what we are trying to do. We are trying to ease out assessment of PNIE and as sir said, regulating PNIE, whether it is through drugs, through mind-body medicine, or through any
Absolutely.
other practice. We don't know. Tomorrow we might find one single pill for everything.
Absolutely.
So we really don't know what would be the future of this, but it needs a regulation of PNI has to be that thought of in all NCDs. That's what it is.
We are also changing our mindset in the sense that, for example, assessing the autonomic nervous system part, as part of the PNI, or even assessing for that matter, immune markers, inflammatory markers, immune markers, assessing the autonomic nervous system could add very valuable information. Again, over there, perhaps we have within our own verticals, we have decided protocols that a diabetologist makes only a certain particular set of investigations. So it's not only in terms of the subjective complaints that the patient is reporting, or it could definitely needs to be, augmented by the objective markers also. And they are already available. And I think that's why this crosstalk is very important. And although this is the last session, but I would say that to my mind, this is one of the most important, because as Professor Sartorius very in an encouraging tone told us that you report it, to the medical community, that there was this very nice dialogue about the psychoneuroendocrine framework, whether there is a neurologist, there is a psychiatrist, there is an endocrinologist, and there is an immunologist, all the specialists, the four people are a grand round sort of a situation, along with a very experienced physician there. And it is very encouraging to know that he is now the chief editor. So I am sure that he would also, Divaskar sir will be happy to, sort of promote idea. He has a very powerful tool as a chief editor, so to promote, bring this sort of a fresh line, we need that, to promote it further within the medical fraternity. So thank you so much, for opportunity.
Thank
So
you. Thank you.
Yeah, I think we started with a particular sort of core topics for each of the experts, and it's gone very nicely into the adjoining areas. And we have some promising rating scales and some homework to be done also. So, but I would, before closing, I would ask our experts to each give us very briefly a take-home message for the audience. So, Tivaskar sir, you can start. Yes,
Yeah.
sir.
Yeah, thank you very much, Vani, and everybody. And in fact, thank you for appreciation and your participation, very active participation. Now, my take-home message is simple. It's this, that appreciate the importance of the mind as a driving force for your health, because mind determines and drives your system, and you must have choose a right driver to drive your life vehicle. It is extremely important to understand that, and that is the place, and that is the reason probably why the lifestyle change, no matter it could be an interventional, therapeutic, or whatever the way, but lifestyle change will always precede the pharmacotherapy, no matter it could be a acute care or a chronic care. It is extremely important to understand that there is one modality which has to be always addressed, is to have a good understanding of PNI. Thank you very much.
Very much. Just one comment from Dr. Joshi.
I don't think this panel discussion as the last session of the present conference, but I take this as the first session of the next conference.
Thank you, sir.
Thank you, Dr. Joshi.
Dr.
you.
Shripad Pujari, your
No, the same thing what Dr. Tivaskar said. Yes, absolutely. Most of the concepts, I suppose, most of the diseases start from the mind, and once we control or modulate our mind, that is where we are going to, give our prescriptions of primary as well as secondary prevention. That's what I would like to say. Yeah.
right. Dr.
Yeah,
Vaishali.
we deal with a pain, lot of pain, and every time pain. So I think mind is a definite driver to relieve that pain or to augment that pain. So definitely mind matters a lot in those conditions. And one more point I wanted to add to Vaishali, that where is the role of this mind-body medicine as far as prevention is concerned? I feel these autoimmune disorders give you a window of opportunity. all the literature tells that what the patient when presents as SLE with clinical manifestations, there is almost a period of 8 to 10 years before when the antibodies have already occurred. So that kind of, yeah. So that in that particular zone, when you are known that you are likely to be predisposed to, now with genetics coming up and like anything, we are going to, in future, we are going to know what we are genetically predisposed to. So in that particular area, if we want to focus on, then where we are landing up with some antibodies already and we are knowing about that. So that is the window of opportunity where mind-body medicine can have a great role before prevention. Yeah.
Yes.
Fantastic.
Thank the organizers to give me the honor to moderate this session. Thank you.
No, Vani, before you conclude, let me appreciate and put on records the tremendous effort by Dr. Vani. And it was a mind-blowing conduction of the entire session. And I would like all of you to give her a very big round of applause to Dr. Vani as well. And also, Vani, final take-home message from you also.
Thank you, Vaishali, for giving all of us the opportunity.
Thank you, Tivaskar sir, for being there on the virtual platform. Thank you so much.
Thank you, Dr. Vaishali. And I wish all of you a very happy time. Bye-bye. Thank you very much.
I thank all our panelists for such interactive as well as informative session. And I also thank Dr. Vani Kulhari ma'am for being an excellent moderator throughout the session. Now I request Dr. Vaishali ma'am to proceed further. Over to you, ma'am.
Yes, before we go to the vote of thanks, I would like to request all the delegates to take their certificates after filling in the feedback forms. The certificates are available at the registration counter. For those who have joined virtually, it's on the virtual lobby after 6 p.m. And feedback forms are essential. They need to be complete with their MCI numbers and their names written rightly on them for the credit point allotment. And we also thank our MMC observer, Dr. Deshmukh, who has been with us virtually. He is not come up front on the screen, but he's been very cooperative and has helped us throughout past 2 days. And we thank him for being there with us throughout the program. So for the vote of thanks, I think we had an excellent discussion since past 2 days. I'm sure that we are going with a lot of promises, lot of homeworks, and lot of food for thought. And as Dr. Joshi rightly mentioned, that this is just the beginning. It's the beginning of a new era, you can say, of thought processes. And I'm sure a lot of you are going with a lot of thoughts in your minds and creative ideas. I hope Dr. Sartorius sir invites us to Geneva. I will pass on this message to him definitely. But we have a lot of promises from the audience that they are ready to host the conference. So I look forward to them, and Sphere is here to support. I'm sure CBM Trust and all our societies are there to support this whole cause. Absolutely. And we are there to support this cause, and we are there. We are thankful that the industry also is there to support us, along with the pharma as well as the doctor involvement, the medical fraternity in being involved. So I think I will pass on the mic to Dr. Padke sir. You want to say something, or I will start?
I want to have a standing ovation for Vaishali.
So thank you, sir, for those kind words, and this is what makes us going. So this is the efforts are worth this praise that we receive at the end, and I'm sure the cause is going to go ahead further also. So I'll just give 5 minutes to Padke sir to express his views, and then we'll have the vote of thanks, sir, by Dr. Madhura then.
Thank you. I won't take long, because I have spoken already a great deal. Yesterday, I spoke the whole day nearly. Today also, I had my opportunity. But let me express a very heartfelt gratitude to all of you, because somehow over a period of time as professionals, we all get conditioned, we follow a certain path. And I must say that it really takes a lot of courage and risk taking, to break free from that path. So I really congratulate all of you. You have shown, you are dared to actually sort of move on an untrodden path. You have chosen to consider something new. You have been open to actually new ideas, experimental ideas, and you have engaged very heartfelt in a heartful way into this whole affair. So I personally feel that all these synapse thing, as I said in the morning, that the first synapse was like a honeymoon thing. And what usually happens, as we say in psychology, that after the initial nice feeling, sometimes the disillusionment sets in. Over here, we are experiencing actually a virtuous cycle, that with every edition of synapse, it is actually picking up more interest. And it is bringing forth, it has actually become a forum, for a wonderful brainstorming, bringing about fresh new ideas in medicine, wherein everyone is together. So we come out of our individual verticals and individual silos, of the specialities. And here we are to discuss some great new ideas. And as Professor Sartorius said, that we shouldn't underestimate, the value of these efforts which happen. Sometimes we have certain ideals in mind and we think that it is only some great people, very highly placed people who are the sources of bringing in fresh ideas. That is not true. Fresh ideas could also come from grassroots people like us. We could bring forth actually fresh ideas and certain advancement in medicine. We should not underestimate our potential. So that is one message that I like to give to you all. It is not necessary, that you have to be a laboratory researcher. It's not only the laboratory researchers who bring in great ideas, revolutionary ideas in medicine. It could be simple practicing people who could very often also be contributing to bringing great ideas. So please keep it up. So this virtuous cycle, and that's why I feel very interested, that now more people express their interest to do this activity. It simply shows that it is not a mere fancy of, one or two or three people, but as more people become the takers to it, it is almost like that more people have started seeing the truth. That we could possibly deliver better outcomes, better quality of life to our patients. We could do more efforts. So that is the second thing for which I really like to congratulate you, because all the people who participate in this conference, they are truly patient centric. I am sure they are not doing, this conference, they are not attending this conference just for the sake of, routine information getting, but they are the people who are investing their time and energy and resource basically to do something, to learn something new, so that finally the benefit could be passed on to their patients. So all the ideals which I would say, which we are taught in medicine, that be patient centric, be open to new ideas, be open to learn, so that ultimately you do something really great and good for society, is actually happening here. These are the nice words that we hear, the ideals, but they are happening here. And I thought that it is therefore very important to give you this feedback, not just merely a, formal sort of a thank, but don't underestimate this great thing which you people are doing. And it is because of your participation. Like she told me that this conference had a peak attendance of 500 people. 500 people attending this conference is quite something. Of this type of conference or specialized conference in some way is quite something. And this makes now a very substantial mass. So just keep it up. Let this flame roll. And we don't want it, really to be a, you can say, an intellectual sort of a fancy intellectual property of a few. You all are free to think. You all are free to think. You all are free to contribute. And any contribution to my mind is equally noble. Whether you are a researcher, whether you are an educator, or whether you are become a good service provider, they all are equally noble. All these roles are equally noble. It is only that, researchers formulate certain ideas, generate some evidence, and it is often presented in conference. So we start to believe, as if the researchers are doing some phenomenally great job. So there is a researcher, an educator, and a service giver in all of us. And I am sure that all of you, this is also going to give you a lot of personal well-being and rejuvenation, because when we are active,
you must remember this is also a typical situation in which the Swarth and Paramartha, our own service and other service, both these ideals are also happening actually in a good way. Perhaps the mind-body medicine, all these fresh interactions is also the best anti-dementia measure for our own cells. There are two types of stresses, we burn out, but the worst part of stress is we rust out. And as we grow older in any profession, there is always a risk that we may rust out. So all you guys, anti-rust, this activity also is a very anti-rust activity for our own selves. So I look forward, to kind of keep meeting you years after years like that. And as I expressed in the morning, that I really kind of go back home as the most contented person. 3 years ago, when this activity started, now this gathers pace. And as they say, the rolling snowball phenomena. As the snowball goes down, it actually gathers, speed, it gathers actually more and more mass, so that is what I see happening. So thank you so much, and really my very heartfelt gratitude to all of you. Thank you so much.
So I think the youngest mind inspired by you, sir, has been, and this conference has inspired Dr. Madhura Samudra. She is a psychiatrist in making. So she'll be doing the vote of thanks for today.
Perhaps also become straightway the first mind-body medicine.
Maybe, hope so.
So they becoming the narrow specialty, she will become a psychiatrist with mind-body medicine.
I really hope so, sir. Good evening, everyone. Thank you, Dr. Vaishali ma'am, for inviting me here. I feel less guilty for skimping out a few hours for my MD final exam preparation now. We have had 2 glorious days of, if I may say so, an academic feast and a plethora of discussions in the field of mind-body medicine. We look forward to seeing you all in the fellowship program as well as another edition of Synapse conference next year. So before we conclude, I would like to extend a vote of thanks to the Society of Prevention, Healthcare, Education and Research, that is FEAR, the CBM Trust, the Endocrine Society of India, Indian Psychiatric Society West Zone Branch, MGM Hospital Aurangabad, Association of Physicians of India, the eminent speakers, orators and faculty who joined us physically as well as virtually, the pharma sponsors, the entire Elysian team for an impeccable conduction of this event, the Grover audiovisual team, all the volunteers for their contribution and their help, the delegates who took time out of their busy schedules to join us from all over the country and virtually from all over the world, the travel team, Team Pride International for their hospitality. It is all of you who made this event a grand success. Thank you.
Dr. Madhura, and I'm sure I must have missed many of the helpers into this, but I think I thank each and every one of you physically, virtually, who have supported, helped the event and make it a grand success. So I welcome you all for the fellowship program and as well as Synapse for the next year. Hopefully we will be doing it in a separate venue next year. Thank you so much.